1, 2,
And review 70-year-old female.
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's
300 please.
I'll keep you on guard again.
Pulse check. No pulse.
no more pulse.
Yeah. Here, what do the ECMO people say? And her blood pressure is off the property.
45 minutes of CPR and no return of circulation. Okay.
You are a critical care clinician, and I want you listening right now to really put yourself into this exact scenario. You're stepping through those heavy double doors into the burn intensive care unit, and, the heat hits you first.
Right, because the rooms are kept absolutely sweltering. The patients they've lost their ability to regulate their own temperature.
Exactly. But as you walk up to the bedside of a major burn patient, you need to realize immediately that you aren't just looking at a wound. You aren't just there to apply dressings. You are looking at absolute, catastrophic, multi-system failure.
It's a complete paradigm shift from almost anything else you'll see in medicine.
Yeah.
And when you walk into that room, you have to stop looking at the skin as just a covering.
Yeah.
You have to treat the massive systemic physiologic shockwave that follows the thermal injury. Because time is tissue. And hesitation in the burn ICU is deadly.
And that's exactly our mission for this deep dive. We're bringing you an elite bedside masterclass on major burn injuries. We're applying the 80-20 rule, so we're stripping away the fluff and focusing strictly on the pathophysiology, the clinical assessments, and the critical actions that dictate survival.
Right, the stuff that actually matters at the bedside.
Exactly. This is the knowledge that will save a patient's life, prevent irreversible injury, and, give you that intensivist level intuition.
Because you really need to know exactly what is happening down at the cellular level. If you understand the micro-level collapse, you can anticipate the macro-level disaster before the alarms ever even sound on your monitor.
So let's build an analogy to kind of hold on to throughout this entire journey. Imagine a highly functioning, fortified city.
Okay, I like that.
A major burn is like that city simultaneously losing its outer defensive walls, its internal water supply, and its communication grid all at the exact same moment.
What?
Yeah, it's a total collapse of systemic boundaries. And that brings us to the most immediate threat when that patient rolls through the doors, the emergent phase, like the first 72 hours.
Right.
But here is where my logic hits a wall. If the wall of the city is what's damaged like, if it's a thermal injury to the exterior of the body, why is the most immediate life-threatening problem essentially severe dehydration and cardiovascular collapse?
It's the perfect question, and it gets right to the core of what we call burn shock. If we're looking at the 80-20 of the emergent phase, you have to understand that burn shock is a deadly hybrid combination of distributive and hypovolemic shock.
Okay, distributive and hypovolemic.
Yeah, and it typically strikes patients with burns covering more than 20% of their total body surface area, or TBSA.
So we're talking about major thermal, chemical, or electrical burns, but what's the actual mechanism? Like, what is the trigger that turns a skin injury into cardiovascular collapse?
So the trigger is the intense heat and tissue destruction, right? Which initiates a localized inflammatory response. But in a major burn, that localized response goes entirely systemic.
It goes everywhere.
Exactly. Capillary permeability massively increases across the entire body. Think of your blood vessels. Normally, they're like semi-permeable pipes keeping the fluid moving forward. Suddenly, the heat and chemical mediators turn those pipes into porous soaker hoses. They completely lose their seal.
So all the fluid components of the blood just start leaking out of the vascular space and into the surrounding tissue, the interstitium.
Yes, and it's not just water. The most critical element you're losing into the tissue is plasma protein, specifically albumin.
Albumin, right.
Yeah, albumin is a massive molecule. Under normal conditions, it stays inside the blood vessel and acts like a molecular sponge. It provides colloidal osmotic pressure, which is essentially the magnetic pull that keeps water inside the blood vessels.
Oh, I see. So when the pipe becomes porous, this giant albumin sponge escapes into the surrounding tissue.
Okay.
And because water follows protein, the magnetic pull is now on the outside of the vessel.
That's it, exactly. The water gets dragged out of the vascular space into the tissues. We call this massive fluid shift third spacing. So the patient's intravascular tank is rapidly emptying, while their physical body is just swelling with liters of trapped fluid.
If the fluid is leaving the blood vessels that rapidly, I mean, my instinct tells me the patient's blood pressure should immediately tank. Is that what I'm going to see on the monitor the second they roll in?
You'd think so, but the human body has incredible compensatory mechanisms that will trick you if you aren't paying attention.
Really?
Yeah. The body senses this profound drop in blood volume. So it kicks into overdrive to compensate. The heart rate shoots up tachycardia to pump whatever volume is left.
Okay, that makes sense.
And the peripheral vessels clamp down aggressively. This vasoconstriction increases peripheral resistance, which can actually artificially hold the blood pressure up in the early stages.
But it's a house of cards.
A very fragile one. And to make matters worse, because you're leaking all this plasma and water, but you're keeping your large red blood cells inside the vessels, the blood becomes highly concentrated. The hematocrit skyrockets.
It's like the heart is trying to pump thick sludge instead of water.
Precisely. You have decreased blood volume combined with increased blood viscosity. The heart is working exponentially harder to push sludge through clamped down pipes.
And then it just fails.
Right. Eventually, this compensation fails, leading to decompensation. True burn shock. The lack of perfusion starves the cells. Potassium, which normally lives happily inside the cell, shifts out of the hemolyzed destroyed cells and floods the bloodstream, causing severe hyperkalemia.
And hyperkalemia is a massive cardiac threat.
Absolutely.
Yeah.
Meanwhile, sodium rapidly shifts into the interstitial space, causing hyponatremia. If you don't correct this empty, sludgy vascular space immediately, the kidneys die, multiple organs fail, and the patient dies.
Okay, so let's translate this to the bedside assessment. I'm looking at the patient. Early on, I'm seeing that compensatory tachycardia. What else?
Surprisingly, you'll often see profound shivering.
Shivering.
Yeah, they've lost their skin barrier, so they're losing heat to the room rapidly, and they're just flooded with adrenaline from anxiety. And regarding pain, this is a massive clinical nuance.
Okay.
If they have partial thickness burns, second degree, it's going to be excruciatingly painful because the nerve endings are raw and exposed. But if they have full thickness burns, third or fourth degree, they might look at you and say it doesn't hurt at all.
Wait, really? Because the fire actually incinerated the dermal nerve endings?
Exactly.
Yeah.
The worse the burn, the less it might hurt initially.
Yeah.
It's a terrifying paradox. Now, as the hours pass, you'll see the classic clinical picture of the fluid shift emerge. Massive, unbelievable edema.
Right, the third spacing.
Yes. The patient's face, their limbs, their torso will swell to the point of being totally unrecognizable.
And what about their urine output? Because if the kidneys are being starved of blood, they must be shutting down production, right?
Urine output is your absolute holy grail of monitoring in the burn ICU. You will see a high urine-specific gravity, meaning the urine is dark and highly concentrated, and a very low output, which is oliguria.
The kidneys are just panicking.
Right. They're desperately holding on to every single drop of water to try and keep the blood pressure up.
So what are the late dangerous findings, like the things that tell me the patient is actively slipping away?
Profound hypotension.
Yeah.
Meaning the compensatory vasoconstriction has completely failed and altered mental status.
Okay.
But a major ICU pearl here. If a burn patient becomes confused, agitated, or restless, do not just assume it's shock or that they're simply in pain. You must think hypoxia first.
The airway.
Yes, we'll cover this deeply in a moment, but you have to rule out an airway threat.
Got it. Since we know the blood is turning to sludge and the cells are rupturing, what numbers in the lab results are going to, sound the alarm?
So your high-yield diagnostics for the emergent phase are going to show that elevated hematocrit due to the hemoconcentration. You'll see hyperkalemia from the massive cellular destruction.
Which puts the patient at immediate risk for lethal cardiac arrhythmia.
Exactly. And you'll see hyponatremia because the sodium is washing out into the tissues.
And we have to quantify the size of the burn to know how much fluid they need, right?
Uh,
This is where the rule of nines comes in to calculate the total body surface area, or TBSA.
Right. The rule of nines is your rapid visual triage tool for adults. You basically visualize the body in sections. The entire head and neck is 9%. Each entire arm is 9%.
Okay.
Each entire leg is 18%. The anterior trunk is 18%, the posterior trunk is 18%, and the perineum is 1%.
So if a patient has burns on their entire chest, abdomen, and both full arms, that's 18 for the trunk, plus 9 for the arms. So 36% TBSA.
Spot on. Now, for more exact calculations, especially in the ICU or for pediatric patients, because their head-to-body ratios are completely different, we use the Lund-Browder chart. It breaks down the percentages much more precisely based on age.
Okay, so I'm at the bedside. I've recognized the massive fluid leak, the impending shock. I've calculated the burn size. What is my literal first move to stop this crash? I have to rank my interventions.
First, you ensure the burning process is stopped, remove hot clothing, chemicals, whatever it is, and you assess the airway. Next, you must establish 2 large-bore IVs.
How large are we talking?
We are talking 14 or 16 gauge or a central line for any burn greater than 20% TBSA. And you must simultaneously insert a urinary catheter.
Let me stop you there. Why is the Foley catheter grouped in with life-saving IV access? It seems like something that could, wait a minute.
It absolutely cannot wait. You cannot safely manage the aggressive fluid resuscitation required to save their life without a Foley to measure hourly exact urine output.
Because that's the holy grail.
Exactly.
Yeah.
The urine output is the only real-time window you have into whether your fluids are actually perfusing the internal organs.
Okay, so airway, large bore IVs, Foley. Then what?
Then you calculate and slam them with the fluid resuscitation.
Let's dive into the math of this fluid, because this is where a critical care nurse saves the kidneys and the heart. We use lactated ringers, YLR, instead of normal saline. Because, we use saline for almost everything else.
Because of the sheer volume you're about to give. Lactated Ringers is an isotonic crystalloid that most closely mimics human plasma. It contains small amounts of potassium, calcium, and lactate, which the liver converts to bicarbonate to buffer acidosis.
Okay.
If you give 10 or 15 liters of normal saline, you will cause a massive hyperchloremic metabolic acidosis, which will just further depress their already struggling heart.
Wow, okay. So we use the American Burn Association, or ABA, formula. Break that down for us.
The standard formula is 2 milliliters of lactated ringers multiplied by the patient's weight in kilograms multiplied by the TBSA percentage.
Let's do a hypothetical. A 100-kilogram patient with a 50% total body surface area burn.
Okay, so 2 ml times 100 kilograms is 200. Times 50% TBSA gives you 10,000 milliliters. 10 liters. That is their fluid requirement for the first 24 hours.
10 liters. But I don't just set the pump to run evenly over 24 hours, right?
No, absolutely not, because the capillary leak is most severe immediately after the injury. You must administer half of that massive total volume, 5 liters, in this case, in the first 8 hours post-injury. The remaining 5 liters are given over the subsequent 16 hours.
Here is a terrifying clinical pitfall that I really want to highlight, something that catches new nurses off guard. We have this patient, they might be in agony from second-degree burns. We need to give them pain medication. The source material is adamant. Intravenous opioids only. Morphine, hydromorphone, fentanyl, push 5E. Why is it a lethal trap to give an intramuscular or subcutaneous injection to a major burn patient right now?
Connect this back to the pathophysiology we just discussed. The tissues are massively swollen, third spaced with fluid. The blood vessels are clamped down, so perfusion to the muscle and subcutaneous tissue is virtually non-existent.
So if I inject morphine into their deltoid muscle?
It just sits there. It pools in the edematous tissue and is not absorbed into the bloodstream. Right, so the patient stays in excruciating pain. So an inexperienced clinician might look at the writhing patient and think, the dose wasn't high enough, and give another IM injection, and maybe a third.
And the patient still hurts. But what happens 3 days later when the capillaries heal? The fluid shifts back and blood flow returns to that muscle.
The muscle is suddenly perfused, and all 3 doses of that IM narcotic are absorbed into the systemic circulation simultaneously.
The patient suffers a massive iatrogenic overdose.
Exactly, and goes into respiratory arrest. That depot effect is why, in the emergent phase, it is the IV route only. You need immediate guaranteed delivery into the vascular space.
That is brilliant and terrifying. Let's talk about another trap. The urine output is low. The patient is oliguric. As clinicians, our reflex is often, they aren't peeing. I should push a diuretic like furosemide to force the kidneys to work.
Never. Giving a diuretic for low urine output in the emergent burn phase is like pouring gasoline on a fire.
Because their intravascular tank is completely empty.
Exactly. Low urine output here is not a kidney problem. It is a perfusion problem. The kidneys are working perfectly by holding on to water because there is no volume in the pipes.
Right.
If you force them to diurese, you will completely empty the vascular space and the patient will code. They need more fluid, not a drug that wastes it.
Is there ever an exception to that rule?
The only exception is for severe electrical burns. In an electrical burn, massive amounts of muscle are destroyed under the skin, releasing a protein called myoglobin into the blood.
And that's bad for the kidneys.
Very bad. Myoglobin is a large molecule that will clog the renal tubules and cause acute kidney failure. In that specific scenario, we increase our IV fluids aggressively to target a much higher urine output, 75 to 100 milliliters per hour. And we might administer an osmotic diuretic like mannitol to flush that heavy sludge out of the kidneys.
Speaking of electrical burns, let's talk about differential diagnosis and pattern recognition. If I'm assessing a patient and I see like a small charred entrance wound on their hand and an exit wound on their foot, but they're complaining of deep, agonizing muscle pain, and their urine looks like dark tea.
You must immediately think electrical burn. We call this the iceberg effect. The visible skin damage looks incredibly minor, almost deceptively so, but electricity follows the path of least resistance, blood vessels and nerves, and generates massive heat when it hits bone. It literally boils the muscle from the inside out.
Wow, so that dark tea urine is the myoglobin from the boiled muscle.
Yes. And you must assume two other things immediately. First, a cervical spine injury, because the electrical shock often violently throws the patient. Second, you must put them on a cardiac monitor immediately because the electrical current disrupts the heart's conduction system.
They're at high risk for VFib.
Incredibly high risk for sudden ventricular fibrillation.
Let's touch on bedside procedures. Tetanus toxoid is a standard injection because the skin's barrier to environmental bacteria is gone. But tell me about the physical mechanics of an escharotomy. What is actually happening there?
So when you have a full thickness, third-degree burn, the burned tissue, the eschar, turns into stiff, leathery armor. It loses all of its elasticity. Now imagine that leathery armor completely circling a patient's arm or leg, a circumferential burn.
And the fluid is leaking into the tissue underneath that armor.
Exactly. As the edema builds up in the muscle compartments underneath, the eschar refuses to stretch. The pressure builds inward. It acts like a literal tourniquet, eventually clamping shut the arteries supplying the hand or the foot. If you don't relieve that pressure, the limb will die.
So what does the clinician do?
An escharotomy. It's a bedside surgical procedure. The physician takes a scalpel and slices lengthwise completely through that leathery eschar down to the subcutaneous fat.
Just slices it open.
Yeah, and you literally watch the tissue instantly spring open and separate by inches as the internal pressure is released and blood flow is restored to the distal limb. They also do this on the torso if a circumferential chest burn is acting like a straitjacket, physically preventing the patient's lungs from expanding.
How are we monitoring their hemodynamics through all this? Our goal is a mean arterial pressure of MAP greater than 65, but the source text notes we should rely on arterial lines and completely ignore manual blood pressure cuffs. Why?
Think about the physical state of the patient's arm. It is massively swollen with liters of third space fluid, and the vessels underneath are intensely vasoconstricted. If you wrap a standard blood pressure cuff around inches of edema and squeeze...
It's just squishing water.
Right. The pressure reading the machine gives you will be completely falsely low or invalid. You cannot titrate life-saving fluids based on a lie. You need the direct, continuous, invasive measurement of an arterial line sitting directly inside the radial or femoral artery.
Okay, deterioration. I'm at the bedside. The patient is getting worse if what?
The patient is getting worse if their urine output plummets below that 0.5 millimolar per kilogram per hour threshold, despite the formula fluids running. They are worsening if the MAP falls below 65. And critically, they're deteriorating if the hematocrit continues rising on sequential lab draws.
Because a rising hematocrit means your IV fluids are just leaking out into the tissues as fast as you put them in. The capillary leak is uncorrected, and the hemoconcentration is getting deadlier.
Exactly.
And how do I handle escalation? Like, when am I just notifying the provider versus calling an immediate rapid response?
You notify the provider if the urine output is trending down or the MAP is borderline so you can get orders to titrate the IV fluids up. You call a rapid response or immediately alert the trauma surgeon if you lose a Doppler pulse in an extremity or if the limb becomes cold and pale.
Because that means I need an escharotomy right now.
Yes, that is an absolute emergency.
So synthesizing this into how an intensivist thinks, the core problem is the capillary leak. The failing physiology is severe intravascular depletion. The immediate threat to life is burn shock and acute kidney injury. The intervention is aggressive lactated ringers via the ABA formula. And the ultimate reassessment tool is hourly urine output.
That is the exact mental model you need to bring to the bedside.
So if I'm stepping away from the bed after surviving those first few hours, I'm burning these 5 core concepts into my brain. Number 1, the pathology is a massive fluid shift causing hemoconcentration. 2, my bedside assessment is looking for oliguria and unbelievable edema. 3, the enemy I'm fighting is hypovolemic and distributive shock.
Perfect.
4, my absolute priority actions are getting those large bore IVs and that Foley catheter secured. And 5, My weapon is the ABA fluid formula, tailored strictly to what the kidneys are telling me.
To put it in a single clinical picture, you are managing an incredibly edematous tachycardic patient requiring liters of precise fluid administration just to maintain enough vascular volume to keep their organs alive.
If you see low urine output and a high hematocrit in the first 24 hours, you think under resuscitation, and you advocate to titrate those IV fluids up immediately.
Fluids will save their kidneys and their heart.
But what if they can't breathe? The fortified city has its water back, but there is toxic smoke in the ventilation system. Which brings us to the hidden killer, inhalation injury.
Yeah, this is huge.
And I have to say, it is absolutely terrifying to me that a patient might look totally fine on a pulse oximeter. They're, sitting on the stretcher talking to you, and then an hour later, their airway completely swells shut and they code. Why is the pulse ox lying to us?
This is one of the most vital concepts in critical care. Inhalation injury is the leading cause of death in burn patients, and the standard pulse oximeter is lying to you because it was never designed to detect toxic gases. It's a fundamental limitation of the technology.
Let's trace the pathophysiology from the trigger. A patient is pulled from a burning building.
The trigger is the inhalation of intense heat, smoke, or noxious chemicals, almost always in an enclosed space. This creates 3 distinct zones of injury. First, above the glottis, the upper airway. This is a thermal injury.
Just raw heat.
Right, the direct heat scorches the vocal cords and the surrounding mucosa, triggering massive rapid edema. Second, below the glottis, the lower airway. The heat usually cools before it reaches the lungs, but the toxic chemical particles in the smoke causes severe chemical pneumonitis.
And the third zone is systemic.
Yes, exposure to toxic gases, specifically carbon monoxide or CO. This is where the deception happens.
Walk us through the biochemistry of carbon monoxide, because this explains the lying pulse ox.
Carbon monoxide binds to the exact same spot on the hemoglobin molecule that oxygen does. But carbon monoxide has about 200 times the affinity for hemoglobin than oxygen.
It's like a bully taking the seat on the bus, and it refuses to get up.
Exactly. It hijacks the red blood cell. So the oxygen literally cannot get on the transport. The patient is suffocating at the cellular level. But a standard SpO2 monitor on the patient's finger just shines a red and infrared light through the tissue to see if something is bound to the hemoglobin.
So it can't tell the difference.
No, it cannot distinguish between oxyhemoglobin, which gives life, and carboxyhemoglobin, which causes death.
So the monitor reads 99% or 100% saturation. The nurse thinks the patient is oxygenating beautifully, but their brain and heart are actually starving for oxygen.
It is chilling, and it happens all the time. The body's compensation for this cellular suffocation is tachypnea. The patient starts breathing faster and faster to try and pull in more oxygen.
Yeah, which doesn't work.
No, because the decompensation is inevitable. Complete airway obstruction from the heat edema and profound tissue hypoxia from the carbon monoxide. All despite that perfect SpO2 reading and even a normal PO2 on a standard arterial blood gas.
Because the PO2 just measures the oxygen dissolved in the plasma, not what is actually bound to the hemoglobin and delivered to the tissues?
Yep.
Okay, so how do we catch this during our assessment? What are the early clues?
You must act like a detective. Was this an enclosed space fire? Look at their face. Do they have singed eyebrows or nasal hair? Are their oral or nasal membranes darkened or blistered? Are they coughing?
And what are the classic findings that confirm it?
Carbonaceous sputum. If they are coughing up sooty, black, or gray spit, they have inhaled smoke deep into their lungs. And the other classic finding is agitation. I cannot stress this enough to new ICU nurses.
No, this is important.
If a burn patient is restless, anxious, picking at their lines, or combative, do not assume they're just in pain or scared.
Agitation equals hypoxia until proven otherwise.
Always. The brain is starving for oxygen, and it manifests as severe anxiety and combativeness.
What are the late dangerous findings, the red flags that mean the airway is actively shutting down?
Extreme hoarseness. If you're talking to the patient and their voice starts getting raspy or whispery, the vocal cords are swelling shut, difficulty swallowing, and the most terrifying sound in the burn unit, stridor.
That high-pitched sound?
Right, that harsh crowing sound when they inhale. That means the airway is a millimeter away from complete occlusion. Oh, and you might hear old textbooks talk about cherry red skin for carbon monoxide poisoning.
Right, I've heard that.
Erase it from your mind. It is an exceptionally late autopsy-level sign. It's very rare in living patients. Do not wait to see cherry red skin before you treat for CO poisoning.
So for diagnostics, if we throw out the standard pulse ox, what do we actually use to detect the carbon monoxide?
High-yield diagnostics require a direct blood draw for a carboxyhemoglobin level. At the bedside, pre-hospital teams and some ICUs use a pulse co-oximeter, an SpCO device. It uses multiple wavelengths of light to specifically identify the carbon monoxide molecule.
And for the lower airway?
For diagnosing the severity of the lower airway chemical burn, the gold standard is a fiber optic bronchoscopy, where a camera is driven down into the lungs.
So my assessment has recognized the enclosed space fire and the singed facial hair. My nursing diagnoses are ineffective airway clearance and impaired gas exchange. My plan is to maintain a patent airway and flush out the carbon monoxide. What is my very first immediate nursing action?
First priority, apply 100% humidified oxygen via a non-rebreather mask at 15 liters per minute. Oxygen is the ultimate literal antidote for carbon monoxide poisoning.
How does that work?
By flooding the alveoli with 100% oxygen, you create a massive concentration gradient that physically forces the carbon monoxide off the hemoglobin, dramatically reducing its half-life in the body.
And my next priority?
You anticipate immediate prophylactic endotracheal intubation. We're talking within the first 1 to 2 hours for patients with severe facial burns or respiratory distress.
Prophylactic, meaning we intubate them even if they're still breathing on their own and protecting their airway. Why?
Because of the edema trajectory. That heat injury above the glottis is going to swell relentlessly over the next several hours. If you wait until the patient is in severe stridor to decide they need a tube,
It's too late.
way too late. The vocal cords will be completely obliterated by swelling. The physician won't be able to see the opening. The tube won't pass. The patient will arrest, and you'll be forced into a bloody, desperate emergency cricothyrotomy through the neck. You intubate early, while the anatomy is still recognizable, to secure the passage before the door swells shut.
Okay then, I elevate the head of the bed to high Fowlers to use gravity to help reduce facial and airway edema, and I send my ABGs and carboxyhemoglobin levels. What other medications might we be pushing here?
The respiratory therapists are crucial here. They may administer aerosolized heparin and N-acetylcysteine, or Mucomyst.
What do those do?
Well, the chemical pneumonitis causes the lung lining to slough off, creating thick, bloody fibrin casts that can physically flood the airways. The heparin and Mucomyst help break down those casts so they can be suctioned out. We also use bronchodilators like albuterol to treat the reactive bronchospasm.
Let's loop back to hemodynamics and fluids for a second. We're pumping this patient full of lactated ringers for their burn shock, but they also have damaged weeping lungs. That sounds like a catastrophic intersection.
It's a razor-thin tightrope. You have to resuscitate them to save the kidneys and reverse the burn shock. But if you give even a little bit too much fluid, it'll third space directly into those damaged lungs, causing profound pulmonary edema and worsening the respiratory failure. You're balancing kidney survival against lung survival hour by hour.
What is the most dangerous complication for patients who survive the initial smoke inhalation?
Pneumonia. The cause is that sloughing of dead respiratory tissue and the loss of the mucociliary escalator. The little hairs that sweep bacteria out of our lungs are burned away.
Then the finding?
The finding is worsening oxygenation, new fever, and purulent secretions. The action is aggressive pulmonary hygiene, frequent suctioning, turning, and precise mechanical ventilation. Pneumonia is the leading cause of death for inhalation injuries in the ICU.
Deterioration. The patient is getting worse
If their restlessness and anxiety increase, if that hoarseness starts turning into stridor, or if their respirations become shallow and rapid, signaling respiratory muscle fatigue.
Escalation is incredibly clear here. Stridor, or rapidly worsening hoarseness, requires an immediate rapid response and a stat intubation. You do not wait for the provider to finish their rounds. You call for the airway team immediately.
Exactly.
So pattern recognition. If I see an enclosed space fire plus confusion plus a perfectly normal SpO2, I am thinking carbon monoxide poisoning.
And you avoid the deadly traps, assuming combative patients are just in pain and trusting a 99% PO2 reading from a house fire victim.
Thinking like an intensivist for the airway, the core problem is airway heat exposure. The failing physiology is progressive glottic edema. The ultimate threat is complete airway occlusion.
Right.
The necessary intervention is prophylactic early intubation. And the reassessment is continuous capnography, watching the end tidal CO2, and drawing ABGs to ensure we're actually ventilating and oxygenating the patient.
That is how you protect the airway and the brain.
If I'm locking in my 5 takeaways for inhalation injury, 1, the pathology is massive heat swelling and carbon monoxide hijacking the blood. 2, my assessment is looking for soot, hoarseness, and unexplained agitation. 3, the complication I'm terrified of is a total airway obstruction. 4, my absolute priority action is throwing on that 100% non-rebreather mask. And 5, the definitive treatment is getting the endotracheal tube secured before the swelling peaks.
Your clinical picture is this: a soot-covered patient with singed facial hair who is becoming increasingly restless and tachypneic despite a monitor showing a perfect oxygen saturation.
If you see increasing hoarseness and stridor, think impending airway loss and do call for stat intubation. Okay. So we've aggressively resuscitated them with fluids, we've saved their kidneys, we've caught the carbon monoxide, and we've secured their airway with a breathing tube. They survive the first 72 hours. The fluid is finally starting to shift back into the blood vessels. We're in the clear, right?
Not even close. You've just survived the initial siege.
Which brings us to the next massive challenge, the acute phase. Sepsis, healing, and hypermetabolism. If the city analogy holds, the walls are still destroyed, but now the scavengers are trying to get in and the city is starving. Why is sepsis the leading cause of death in this phase, and how does the body's own drive to heal become a double-edged sword?
So the 80-20, the acute phase, is this. It begins when the capillary leak seals and the fluid starts to mobilize back into the vascular space. You'll see this clinically as a massive diuresis. Their urine output will suddenly jump.
Like they start peeing out all that fluid.
Yes. This phase lasts for weeks or months until the burn wounds are completely closed by healing or surgical grafting. And the absolute must-know facts are that infection and sepsis are now your greatest enemies.
Right.
The massive hypermetabolic drive demands immense, early, aggressive nutrition. Surgical excision and grafting are the definitive treatments. And as the nurse, you have to fight against highly preventable, devastating complications like curlings, ulcers, and joint contractures.
Let's track the pathophysiology here. The trigger is the prolonged, massive loss of the skin barrier, combined with profound systemic immune depression from the trauma. What is the physiologic change happening in the body?
Because the physical barrier is gone, the burn wound inevitably becomes colonized by flora. And we aren't just talking about normal skin bacteria. Hospitals breed vicious, multi-drug-resistant, gram-negative bacteria like Pseudomonas aeruginosa, which thrives in moist burn tissue.
Oh, nasty.
Very. At the same time, the body is mounting a monumental stress response. It releases massive, sustained levels of catecholamines, epinephrine, and norepinephrine, and cortisol.
And what does that chemical cocktail do to the patient's metabolism?
It drives their resting metabolic expenditure through the roof, increasing it by 50 to 100% above normal. Their core body temperature resets higher, constantly running a baseline fever. They are burning through calories at an astronomical rate just to exist.
The body's compensation for this is massive gluconeogenesis, right? The liver is cranking out tons of glucose for energy, and it starts cannibalizing the body's own protein. It's literally breaking down skeletal muscle to fuel the wound healing process.
Yes, they will melt away in front of your eyes if you don't intervene. And the decompensation occurs when that localized wound colonization breaches the weakened immune defenses and goes systemic.
Gram-negative bacteremia.
Which leads to sepsis, which rapidly plummets into septic shock, causing massive vasodilation. And finally, multiple organ dysfunction syndrome, or MODS.
Let's talk about bedside assessment. Early on, I'm looking at the wound beds every time I change a dressing. I might see localized inflammation, induration, or redness at the margins. What are the classic systemic findings in this hypermetabolic acute phase?
You'll see transient hyperglycemia. Their blood sugars will be high, often requiring an insulin drip, not because they're diabetic, but purely because of the stress response and gluconeogenesis. You'll see high white blood cell counts, and you'll see that massive caloric demand. If they are underfed, you'll see profound weight loss and delayed wound healing, because the body simply lacks the building blocks to create new tissue.
What are the late, dangerous findings that scream, this patient is crossing the line from colonized to septic?
This is a critical nuance for ICU nurses. Yes, a spiking high fever can mean sepsis, but hypothermia, a sudden unexpected drop in core body temperature, is an exceptionally grave sign of late sepsis and complete immune exhaustion.
Wow, so their body just stops.
Their body literally gives up the fight. You'll also see their blood pressure dropping, requiring vasopressors, their urine output plummeting again as the kidneys take another hit, and new onset altered mentation. In older adults, sudden unexplained delirium is often the very first sign of a systemic infection.
Diagnostics for the acute phase. We're watching the WBCs creep over 15,000 or 20,000. We're taking routine wound cultures, watching for that pseudomonas or even fungal infections like candida taking over, daily blood glucose checks, and tracking albumin and prealbumin levels.
Yes, prealbumin is highly sensitive. It gives you a real-time window into their nutritional status and whether your feeding regimen is actually working.
My ADPIE framework here. Assessment means meticulously monitoring wound beds for purulence, tracking the core temperature, and watching systemic perfusion. My nursing diagnoses are risk for infection and imbalanced nutrition, less than body requirements. My plan is to prevent sepsis and initiate enteral feeds immediately.
And your implementation starts with the first priority nursing action, strict infection control.
Right.
You're not protecting yourself from the patient, you're protecting the immunosuppressed patient from the environment. That means strict use of disposable hats, masks, gowns, and gloves whenever those wounds are exposed.
My next key priority is pain management. The source material makes a very specific distinction here that I want to explore. Background pain versus treatment-induced pain.
It's a vital distinction. Background pain is the continuous, throbbing, relentless pain of the injury itself. This is managed by a steady baseline of 5-E opioids, perhaps a PCA pump, and adjuvant medications like gabapentin for nerve pain.
And the other kind?
Treatment-induced pain is the agonizing, acute spike in pain caused by you, the nurse, doing dressing changes, scrubbing the wounds, and doing physical therapy.
So the action is I must administer pain medications, and often anxiolytics like lorazepam, well before I begin that agonizing wound care.
Absolutely. If you wait until you're pulling off bandages to give the medication, you have failed the patient. You pre-medicate, wait for peak effect, and then proceed. Then your next priority is assisting with early physical therapy and massive nutritional support.
Let's talk medications. We're using topical antimicrobials like silver sulfatazine cream directly on the burns, but there's a safety alert there.
You must check for a sulfa allergy before applying it and monitor their white blood cell count, as it can cause a transient leukopenia.
We also give GI medications, proton pump inhibitors like esomeprazole or H2 blockers. Why are we so worried about the stomach in a burn patient?
To prevent a Curling's ulcer. During that intense stress response, the body shunts blood away from the gastrointestinal tract to protect the brain and heart. This ischemia, combined with excess acid production, rapidly leads to mucosal erosion and massive GI bleeding. The PPIs neutralize the acid.
But the text says early enteral feeding-like. Putting a tube down into their stomach or jejunum and pumping in high-protein formula within hours of the injury is also protective against ulcers.
It's arguably more protective than the drugs. Feeding the gut maintains blood flow to the intestinal lining. More importantly, it prevents the intestinal villi from atrophy. If the gut starves, the barrier breaks down, and the bacteria living in the gut can translocate directly into the bloodstream, causing sepsis from the inside out.
Wow.
Yeah, enteral feeding isn't just for calories, it's a vital infection control measure.
We also give insulin coverage for the hyperglycemia and enoxaparin for VTE prophylaxis because these patients are bedbound, immobilized, and highly inflamed, which is a perfect storm for blood clots. Let's talk about the surgical procedures. The burn team takes the patient to the OR for excision and grafting. What physically happens?
The surgeon takes a specialized tool and physically slices away the dead necrotic eschar layer by layer until they reach healthy bleeding fascia. You have to remove the dead tissue because it's just a breeding ground for bacteria. Then they cover that massive raw area with a graft.
There are several types of grafts, and the terminology can get confusing. Break them down.
An autograft is the holy grail. It's the patient's own skin, usually shaved from an unburned donor site on the thigh or back using a dermatome. It's permanent, and the body will not reject it.
But it's usually small pieces, right?
Right, because donor skin is often limited, they run the autograft through a mesher, which cuts tiny slits in it so it can stretch like a chain-link fence to cover a larger area.
But what if the burn is 80% of their body and they simply don't have enough unburned skin to use as a donor site?
Then we use an allograft, which is cadaver skin. It is temporary. The patient's immune system will eventually reject it after a few weeks, but it acts as an incredible biological dressing to stop fluid loss, reduce pain, and buy time. We also use CEA-cultured epidermal autografts. We take a tiny biopsy of the patient's unburned skin, send it to a lab, and over 3 weeks they grow massive, fragile sheets of the patient's own epidermis. Finally, there's Integra, which is an artificial dual-layered dermal matrix used to build a foundation for massive reconstructive burns.
Let's check in on hemodynamics during the acute phase. We were pumping them full of fluid earlier. Are we still worried about dehydration?
No, the threat has entirely flipped. We are now watching closely for fluid overload. Remember those 10 liters of fluid we pumped into the interstitial space? The capillaries have now healed and regained their seal, so all that trapped fluid begins shifting back into the vascular space to be filtered by the kidneys.
So their blood volume suddenly expands massively.
Exactly. In a young, healthy patient, they just pee out liters of urine. But in older adults or patients with a history of heart failure, this massive, rapid return of fluid can overwhelm the heart, causing congestive heart failure and flash pulmonary edema. You have to watch their lung sounds and oxygenation closely during this diuresis phase.
And electrolytes. What's the trend?
We often see hyponatremia. They are losing sodium through excessive GI suction, massive wound drainage, or dilutional hyponatremia if they're drinking too much free water without electrolytes. We also see hypokalemia because the potassium shifts back into the cells and is lost through the massive diuresis.
Complications. We discussed the curlings, ulcer, and sepsis, but let's talk about contractures, because this is where bedside nursing care literally dictates the patient's future quality of life.
As burns heal and as skin grafts take, the new scar tissue inherently shrinks and tightens. Now, physiologically, our flexor muscles, the ones that pull our limbs inward, are much stronger than our extensor muscles. If a burn patient is left in bed to lie in a comfortable fetal position.
Which is exactly what they want to do because they're in pain and cold.
Exactly. If you let them do that, their joints will freeze in flexion. The scar tissue will literally fuse their chin to their chest. It'll lock their arms in a bent position. They will become functionally disabled, requiring massive corrective surgeries down the road.
So the nursing action is active range of motion, pushing through the pain, and proper rigid splinting. The text emphasizes NO pillows for ear or neck burns. Why?
Because a pillow naturally flexes the neck forward, encouraging a devastating neck contracture. Also, the pressure of the head resting on a pillow can completely destroy the exposed, fragile cartilage of a burned ear, causing it to necrose and fall off.
Oh, wow. So what do you do instead?
Instead of a pillow, you place a rolled towel under their shoulders to hyperextend the neck backwards. You must stretch their tissue, even when they're begging you to stop. It's brutal, but it's the only way to save their mobility.
Deterioration. The patient is getting worse
if the blood pressure drops again, requiring vasopressors, if the urine output falls, and if the temperature spikes or plummets. I will say it again, hypothermia in this phase is a grave sign of late sepsis.
Escalation. Notify the provider immediately for new, foul-smelling, or purulent wound drainage, or sudden delirium in an older adult. You call a rapid response if the hemodynamics indicate septic shock.
Let's do some differential pattern recognition. If you see tachycardia, hyperglycemia, and a completely normal blood pressure, think normal hypermetabolic state. The body is just running incredibly hot to fuel the healing process. Continue feeding them and managing pain.
But if you see tachycardia, a dropping blood pressure, and a dropping urine output, think sepsis and septic shock.
Exactly. Draw pan cultures, start broad-spectrum antibiotics, and prepare for pressors.
ICU pearls and exam traps for this phase. Trap. Letting a burn patient heal in a flexed position because it's comfortable, they must be stretched. For pearl, enteral nutrition isn't just for calories, it protects the gut barrier from breaking down.
Thinking like an intensivist for the acute phase. The core problem is the massive open wound. The failing physiology is severe immunosuppression and hypermetabolism. The lethal threat is gram-negative sepsis.
Right.
The intervention is early surgical excision, strict PPE, targeted antibiotics, and massive caloric support. The reassessment is watching hemodynamics, prealbumin, and white blood cell trends.
If I'm locking in my 5 takeaways for the acute phase, 1. The pathology is a hypermetabolic engine and an immunosuppressed system acting as a magnet for gram-negative bacteria. 2. My assessment is hyper-focused on wound purulence, temperature instability, and dropping urine output.
Perfect.
3. The complication I'm terrified of is sepsis progressing to multiple organ dysfunction syndrome. 4. My priority actions are early enteral feeding, strict infection control, and aggressive, proactive pain management. And 5. The definitive treatment is getting them to the OR for excision and autografting.
Your clinical picture is a diuresing patient with healing but exquisitely painful grafts, requiring massive continuous caloric intake and meticulous infection control to stave off systemic sepsis.
If you see hypothermia, dropping urine output, and mild confusion in the acute phase, you think gram-negative sepsis, and you aggressively escalate for pan cultures and pressor support.
And that eventually brings us out of the acute phase and into rehabilitation, which brings up a profound concept touched on in the source text.
Post-traumatic growth.
Yes. We spend all our time as clinicians in the ICU, hyper-focused on managing fluids, titrating electrolytes, supporting hemodynamics, and protecting grafts. But the most challenging, enduring scar to heal is psychological. A major burn injury is arguably one of the most physically and psychologically devastating traumas a human being can survive.
There is survivor's guilt, profound fear of disfigurement, the absolute agony of physical rehabilitation, and the loss of independence.
But the research on post-traumatic growth shows that this immense distress and trauma can act as a catalyst. Many survivors, after navigating the darkness, remark on a completely renewed appreciation for life, shifting priorities, and a deeper sense of personal strength. We talked at the very beginning of this deep dive about the skin being the literal boundary between the self and the world.
The wall of the city.
Right. When that boundary is violently destroyed and then painstakingly surgically rebuilt over months, the patient must fundamentally rebuild their psychological identity as well. The person they were before the fire is gone. They have to forge who they will be after.
And that is the ultimate, true job of the ICU nurse and the interdisciplinary burn team. You aren't just adjusting pumps to keep the organs alive. You are managing the pain, building trust, and protecting the person inside until they are strong enough to face the world again.
It is an incredibly heavy responsibility, but it's one of the most phenomenal and rewarding things you can do in medicine.
Thank you for joining us on this intense deep dive into the burn ICU. Keep questioning the monitor, keep connecting the cellular dots, and always stay curious.